Assalamu alaikum wa rahmatullahi wa barakatuh. Today I will discuss a very important topic, very relevant to our practice, which is radiology and classification of acetabular fractures. I have based this presentation on the following references and resources, including Orthopaedic Trauma Association, AO Surgery Reference, AO Trauma Book, Fractures of the Pelvis and Acetabulum, Fractures of the Acetabulum book by Emile Letournel and Robert Judet, Acetabular Fractures book by Axel Ganselin, Ortho Bullets. In addition, I would like to acknowledge Fred Baumgartel as well as Emmanuel Gauthier, in addition to my dearest professors and colleagues in pelvic trauma and arthroplasty units in Cairo University hospitals. The eyes do not see what the mind doesn't know. I would like to start by this famous quotation, which we all might have heard in our medical school, to emphasize the fact that without study and acquisition of knowledge, one would miss many clinical signs and clues. So in this presentation, I will try to shed some light on applied anatomy and column theory, different X-ray views, radiographic lines and their anatomic correlates, 2D and 3D CT scan, and finally, a rather simplified algorithm for classification of acetabular fractures. So let's start with the osteology. In 1966, Judet and Letournel came up with the two-column concept. According to this concept, the acetabulum is located at the apex of an arch formed by an inverted Y. This inverted Y consists of the longer anterior column, which is greenish in color here, as well as the shorter posterior column, which is brownish in color here. So starting with the anterior column or the iliopubic column, which is brownish in color here, it consists of the anterior part of the iliac wing, in addition to anterior half of the acetabulum, superior pubic ramus and pubic body. The posterior column or ilioischial column, which is bluish in color here, this consists of the posterior part of the iliac bone below the upper border of the greater sciatic notch, ischial ramus and body. And to understand the radiographic evaluation of the acetabulum, we need to appreciate that radiographic lines represent the bone where the X-ray beam is tangential to its surface. So they are tangents to concavities and convexities. They are like a sort of shadows and they don't always correspond to the anatomy of the bone. And on the bone model, you can't hold them by hand. So actually they represent accumulative densities and do not always have an obvious anatomic correlate. So while rotating the patient, changing its position, you would be able to change the lines. And by interpretation of these lines, you would be able to predict which fracture type and classify it. We need also to appreciate that the innominate bone has a propeller form and that the plane of the obturator foramen is situated perpendicular to the plane of the ala of the ilium. So when we obtain an AP view, we see both obturator foramen and iliac wing obliquely. So we need to turn the patient to see both of them end on. So by turning the patient 45 degrees internally, the X-ray beam will be perpendicular to the plane of the obturator foramen. So we could see the related fracture lines, details, and patterns. And here is the obturator oblique view. This would be similarly the same by turning the patient 45 degrees externally. In this case, the X-ray beam will be perpendicular to the plane of the iliac wing, so we could see the related fracture lines, details, and patterns. And here is the iliac oblique view. So just to recap, the plane of the obturator foramen is situated perpendicular to the plane of the ala, so you need to examine the innominate bone in two 45 degrees views. So for proper assessment of acetabular fractures, we would like to request 3 views, including AP, obturator oblique, as well as iliac oblique view. In addition, we would need to evaluate and interpret 6 radiographic lines. This slide shows how we position the patient and the X-ray beam to obtain an AP pelvic radiograph. So the AP pelvic radiograph would give us an idea about the amount of fracture displacement, congruency of the femoral head and the acetabulum, bilateral acetabular fractures, femoral head fractures, associated pelvic ring injuries. In addition, we would be able to classify the fracture based on proper interpretation of the 6 radiographic lines and landmarks. These 6 radiographic lines on the pelvic AP view include the following: anterior rim line, which represents the anterior wall, so disruption of this line would reflect an anterior wall fracture. Similarly, the posterior rim line, which represents the posterior wall, and iliopectineal line, which represents the anterior column, ilioischial line, which represents the posterior column, the roof or the dome of the acetabulum, and finally the teardrop. And this is how to obtain an obturator or internal oblique view with the injured side of the patient up. In this view, we could see the obturator foramen in profile. It highlights the pelvic brim, anterior column, as well as posterior wall. And this is how to obtain an iliac or external oblique view with the patient injured side down. This view highlights the posterior column, anterior wall, in addition to posterior border of the innominate bone. So on the obturator view, we could review the anterior column and posterior wall. At the same time, we could see the iliac view on the other side and would be able to review the anterior wall, posterior column of the contralateral side. So coming now to the radiographic U-shaped or teardrop. This consists of an external limb, which is formed by the middle 1/3 of the cotyloid fossa, an internal limb, which is formed by the outer wall of the obturator canal, in addition to an inferior border, which is formed by the ischiopubis notch. This is the teardrop lateral portion or the external limb, which is orange in color and is formed by the middle 1/3 of the acetabular or cotyloid fossa. And this is the teardrop medial portion or the internal limb, which is orange in color and is formed by the outer wall of the obturator canal. Now coming to the acetabular roof or the dome of the acetabulum, which is the most important area as it's representative of the superior weight-bearing area of the acetabulum. Disruption of this line might reflect anterior or posterior column injury. And this is the roof arc, which was initially described by Mata in 1986. And it's a way to determine if the remaining intact acetabulum is sufficient to maintain a stable and congruous relationship with the femoral head. A vertical line is taken from the center of the femoral head. A second line extends from the same center to the fracture plane, and all roof arcs should be more than 45 degrees to allow sufficient femoral head coverage. We have to appreciate that some landmarks belong to both columns, including acetabular roof, teardrop, as well as obturator foramen. In cases of combined pelvic and acetabular fractures, we would like to request inlet view as well as outlet view, which have been explained in the first lecture. Now coming to the CT scan. And the CT scan is quite valuable in assessment of acetabular fractures. And for proper assessment, we would like to request thin acetabular cuts every 1 to 2 millimeters through the pelvis. The CT scan is of great benefit in identification of fracture lines not visualized by radiographs, evaluation of acetabular wall fractures, intra-articular loose fragments, marginally impacted fragments, in addition to evaluation of the degree of fracture comminution. We would also be able to evaluate the orientation of the fracture lines, rotation of the fracture fragments, joint congruence, the position of the femoral head and femoral head lesions, evaluation of the sacroiliac joint as well as posterior pelvic ring injuries, in addition to postoperative assessment of reduction as well as fixation. We could evaluate columns and walls on the CT axial cuts by drawing two imaginary lines. The first line is horizontal 1, and it divides the acetabulum into anterior part, which is greenish in color, as well as posterior part, which is brownish in color. Then another imaginary vertical line which separates the column from the wall. It separates the red triangle representing the anterior wall from the greenish anterior column. Similarly, it separates the blue triangle representing the posterior wall from the brownish posterior column. In addition, the 2D CT scan is of great benefit in classifying acetabular fractures by evaluation of the orientation of the fracture lines at the level of the superior weight-bearing dome as well as the level of the walls. So here is the orientation of the fracture lines in cases of wall fractures. And here's a posterior wall fracture orientation on the 2D CT axial cut. In cases of fracture of one or of two columns, the fracture line orientation is horizontal and would be seen traversing from medial to lateral through the weight-bearing dome. Whereas in cases of transverse fractures, the fracture line would have an anteroposterior or vertical orientation and would be seen crossing anterior and posterior columns and dividing the acetabulum into lateral superior and medial inferior portions. So just to recap, there would be a horizontal fracture line orientation in fracture of one or of two columns, represented here by the red line, whereas the fracture line orientation would be vertical or in an AP direction in transverse fracture, which is represented here by the yellow line. So let's review this fracture line orientation. Is it vertical or horizontal? Correct, it's vertical, and it has anteroposterior orientation, so it would represent a transverse fracture. However, there is in addition an associated posterior wall fragment, so this fracture would be transverse with posterior wall fracture. Likewise, the 3D CT scan is of great benefit in assessment of acetabular fractures. It is converted from two-dimensional CT scan data. It provides a good overall picture of the fracture configuration. In addition, it would allow subtraction of the femur, rotation of the pelvis, and you have to appreciate that all information is on the 2D CT. In addition, CT simulated X-rays could be obtained and is possibly a satisfactory replacement for standard X-rays for diagnostic purposes. Finally, manipulation under anesthesia and dynamic stress fluoroscopy is a very valuable tool in evaluation of hip stability. So let's start discussing about acetabular fracture classification. No perfect classification has been yet constructed due to many variables. The famous classification of Letournel and Jodet in 1964 is the most widely used classification and the most practical classification. This classification is based on the columns as well as walls of the acetabulum, and it includes two types, elementary types as well as associated types. The elementary fracture types includes posterior wall, posterior column, anterior wall, anterior column, as well as transverse. The associated fractures include posterior column and posterior wall, transverse with posterior wall, T-shaped, anterior with posterior hemitransverse, as well as both column. So let's start with the posterior wall fracture. And this is the most common acetabular fracture and account for approximately 24%. As we could see here, the only radiographic landmark which is disrupted is the posterior rim representing the posterior wall, in addition to the dislocation of the femoral head, while the other 5 radiographic landmarks are not disrupted, including the iliopectineal line, the ilioischial line, the teardrop, the roof, as well as the anterior rim. And that's how it looks after reduction of the femoral head, again with disruption of the posterior rim representing injury to the posterior wall. And that's how it looks on the obturator as well as the iliac view. And as we could see here, usually we could appreciate the displacement of the posterior wall mainly on the obturator view. In addition, there is also the seagull sign, which could be encountered in some cases of posterior wall fractures. That's how the posterior wall fracture would look on the axial CT scan cuts. Some posterior wall fractures might be associated with marginal impaction, where there is crushing of the posterior acetabular surface. As mentioned previously, a 3D rendered CT scan can be obtained to confirm the assessment made with the plane radiographs as well as the axial CT scans. And this is the second elementary fracture type, which is the posterior column fracture, which is rather a rare fracture occurring in about 3% of acetabular fractures. And this is the anterior wall fracture. There is also an isolated anterior column fracture, which might include different variants, including very low variant as well as low variant, in addition intermediate variant as well as high variant. And the fifth elementary fracture type is the transverse fracture, and this is a fracture through anterior as well as posterior columns. It is subclassified based on the level of the fracture through the acetabulum, and it's often associated with a posterior wall fracture. This fracture divides the acetabulum into upper portion, including the ilium with the roof, in addition to lower portion, including the ischium and the pubis, and it's usually associated with rotational malalignment. So the transverse fracture might run at different levels through the acetabulum. So there are three subtypes of transverse fractures, including transtectal, which is a fracture through the roof of the acetabulum, juxtatectal, which is a fracture through the highest point of the cotyloid fossa, in addition to infratectal, which is a fracture through the cotyloid fossa itself. As we've mentioned previously, that the anteroposterior orientation of the fracture line on the CT scan is diagnostic feature of the transverse fractures. Now, coming to the associated types, including the posterior wall and posterior column, transverse with posterior wall, T-shaped, anterior with posterior hemitransverse, as well as both column fractures. And this is the posterior column, posterior wall, transverse with posterior wall, which is considered a fairly common fracture. And this is how it looks on the axial CT scan cut, where there is an anteroposterior orientation of the transverse fracture with associated posterior wall fragment. And here is the T-shaped acetabular fracture, which includes all fractures with transverse fracture of the acetabulum with an associated vertical component. And the transverse component is quite identical to the pure transverse fracture, in addition to the vertical fracture line passing through the obturator foramen. And as we could see here, the T-shaped fracture might have different possible inferior fracture line exits. There is also anterior column with posterior hemitransverse, and the anterior column component is usually high and is associated with minimally displaced posterior hemitransverse component. This fracture is commonly encountered in the geriatric patient population. And now coming to the last associated fracture type, which is associated both column fractures, or ABC. This is usually a fracture of both columns of the acetabulum, where no articular surface remains attached to the axial skeleton. So it's a complete articular fracture, and we usually call it floating acetabulum. This fracture usually associated with central dislocation of the femoral head. This slide shows the different variants of associated both column fractures. Here is a classic example of associated both column fracture, where all 6 radiographic landmarks are disrupted, in addition to central dislocation of the femoral head. This fracture is usually associated with one of the pathognomonic signs, which is called spare sign. And this sign actually represents the inferior tip of the fractured ilium, which is seen lateral to the medially displaced acetabular fragment. And here is a transverse CT image of a spare sign. And the yellow line represents horizontal fracture line, indicating a both column fracture. So now I'm going to present a rather simplified algorithm of commonly encountered acetabular fractures. So to start with, I would like to remind you with the following radiographic lines, including the anterior rim, which represents the anterior wall, posterior rim, which represents the posterior wall, iliopectineal line, which represents the anterior column, ilioischial line, which represents the posterior column. In addition, we would need to review the X-ray to check for any disruption of the obturator ring as well as the ischiopubic ramus, or any fractures extending into the iliac wing. So this simplified algorithm for classification of acetabular fractures would start by checking the presence of any disruption of the posterior or anterior rims lines only. So in case if there is any disruption of the anterior rim, this would present anterior wall fracture. And in case of any posterior rim disruption, this would reflect posterior wall fracture. Next to that, we need to evaluate the iliopectineal as well as the ilioischial lines. If there is disruption of the iliopectineal line, this would present anterior column fracture. If there is disruption of the ilioischial line, this would present posterior column fractures. And if there is an associated disruption of the posterior rim, this would represent associated posterior column with posterior wall fracture. If there is disruption of the four lines, including the iliopectineal, ilioischial line, posterior rim as well as anterior rim, with intact obturator ring and iliac wing, this would represent a transverse or transverse with posterior wall fracture. Next, we need to check for the presence of any disruption of the obturator ring or the ischiobiopic ramus, and also if there is disruption to the iliac wing. In case of disruption of the ischiobiopic ramus and intact iliac wing, this would represent a T-shaped fracture, where here we could see disruption of the iliopectineal, ilioischial, anterior wall, posterior wall, in addition to disruption of the ischiobiopic ramus. Finally, if there is in addition disruption of the iliac wing fracture, in addition to disruption of the other radiographic lines, this would occur in associated both column fracture, and this is associated with floating acetabulum as well as spare sign. Just to summarize this simplified algorithm again, we need to check for the presence of any disruption of the posterior or anterior rims lines only. So if there is disruption of the posterior rim only, this would represent a posterior wall fracture, and in case the disruption was in the anterior rim, this would represent anterior wall fracture. And if there is disruption of the iliopectineal line, this would represent anterior column fracture, and ilioischial line disruption, this might represent posterior column or posterior column with posterior wall fracture in case if there is an associated posterior rim fracture. Next to that, if the four lines disrupted, including posterior as well as anterior rims, iliopectineal as well as ilioischial lines, if it's associated with intact obturator ring as well as iliac wing, this would represent transverse or transverse with posterior wall. Next, we need to evaluate if there is any extension of the fracture lines into obturator ring, ischiobiopic ramus, as well as iliac wing. So if there is disruption of the obturator ring, ischiobiopic ramus, in addition to intact iliac wing, this would represent T-shaped fracture. And in case if there is obturator ring, ischiobiopic ramus, as well as extension of the fracture into the iliac wing, this would represent both column fracture, and this is usually called floating acetabulum and associated with the pathognomonic spare sign. And to conclude, I hope during this lecture I was able to shed some light about the applied anatomy and column theory, different radiographic landmarks and lines, different X-ray views used in assessment of acetabular fractures, in addition to the role of the CT scan, the commonly used classification system, and finally a simplified algorithm for classification of the commonly encountered acetabular fracture types. Thank you very much.